everyone. I think we'll go ahead and get started. We have a lot to cover today. Before we start with our fellows research presentations, we have a special presentation that Dr. Kristen Carroll will be introducing, and we'll go from there.
So good morning, everybody. As chair of the Equity, Diversity, and Inclusion Committee for our department, it is my real pleasure to introduce Ariel Malan. So I've listened to Ariel's presentation a few times. She has a master's degree in healthcare administration from the University of Utah and is a true advocate and educator for the LGBTQ plus community, and we are honored to have her. She works in the transgender clinic at the University of Utah. She's on the board of directors of the Pride Center. She's just fabulous. So she's going to give us just a 15-minute talk. I know it's not very long, but it's sort of the first talk on gender sensitivity, sort of in medicine. How we're sensitive with each other, how we're sensitive with our patients, and how we can make everybody feel more included and more welcome in our medical practice and as our partners and friends. So thank you so much, Ariel. Take it away. Thanks.
Thanks, Dr. Carroll. I think I'm going to write that in my new bio as my introduction that I give people. Just fabulous. Okay, so like Dr. Carroll mentioned, this is a really short presentation, but it's going to cover some pretty foundational and basic topics. And then I will provide all of these slides to y'all at the end because they have a lot of resources and links. So we'll just go ahead and get started. So first, we'll kind of go over some terminology and concepts. So ultimately, I like to use this slide as kind of a first reference to these concepts to kind of reiterate the fact that ultimately everyone has a sexual orientation, a gender identity, a gender expression, and a sex assigned at birth. But these things are not mutually exclusive of each other, meaning that someone's gender identity will not necessarily indicate what their sexual orientation will be or their gender expression and vice versa. So a lot of the terminology that we use has evolved over time, and how people identify also changes over time. So we like to approach these concepts from a very fluid perspective, and that's why these are also depicted on a spectrum. It's also important to remember that these are self-identifiers, meaning our patients have the right to self-identify in any way that they see fit, and this is regardless of our understanding of any of these terms. And that's completely okay. So people may have different definitions of what these terms mean, and that's okay too. So it's more just about being familiar with the breadth of terminology and mirroring the language that your patients are giving you, which we'll talk about. So starting with this concept of sex assigned at birth, this is sometimes referred to as biological or anatomical sex. It's the sex that an infant is assigned when they're born, and this is usually based off of external genitalia or physical characteristics. So without extensive testing, we can't actually determine an infant's sex based on their chromosomal makeup, their hormone levels, or other sex characteristics, despite the fact that sex is extremely variable. Folks who fall outside of that binary male-female assignment are defined as intersex. And intersex people are sometimes born with differences in sex development. So these are can be noticed at birth. Sometimes they don't show up until puberty or even later in life. So sex assigned at birth is typically what will be present on legal documents, unless someone has gone through the process to change their gender marker on their IDs. So this is why most electronic medical records, including Epic, list both legal sex and sex assigned at birth. So we can't actually look at someone's legal sex and expect that to give us any information about a person's organs or their health needs. So it's important to differentiate between legal documentation and a patient's sex assigned at birth. So gender has commonly been misperceived as sex assigned at birth, but gender is actually more of a social construct that's defined by the culture that we live in. And for Western society, the binary of male, female, man, and woman is kind of what we have. When a child is assigned female or male, that information is then used to gender the child. So gender roles, blues versus pinks, girls' toys versus boys' toys, and so on. Gender identity, which you'll hear, is our internal sense of gender. It's who we feel like we are. So that's why it's impossible for us to know someone's gender without them disclosing that information to us. It's also important why we shouldn't assume someone's gender based on their name, their appearance, or even how their voice might sound. Gender expression is another kind of concept within this realm, which is that outward expression of our gender, which can be depicted through things like clothing, hairstyles, body language, etc. And again, just because someone identifies a certain way will not necessarily predict what their gender expression will be. So some terms on the left you might hear with your patients, starting with cisgender. This refers to someone who identifies with the sex they were assigned at birth. So for example, an assigned female at birth individual that identifies as a woman. So those two things align. The remaining terms are not a comprehensive list of gender identities by all means, but it's a kind of a good start to start identifying what gender diversity can look like. So transgender refers to someone who doesn't identify with that sex they were assigned at birth. So this could be, for example, an assigned male at birth individual who identifies as a woman. So those two things are misaligned. And there can be a lot of different combinations of that. This is just kind of one example. And then these last three identity terms are becoming increasingly more common as language evolves to support the fluidity of gender. So non-binary and gender fluid identities are part of the gender diversity umbrella, just like transgender. However, these identity groups are sometimes even more stigmatized, even specifically in healthcare settings, because they may not ascribe to that binary of man and woman that we typically see. So there's a lot of stigma and discrimination associated with that. So although there are many transgender people whose goal is to medically transition, so in order to reduce those feelings of gender dysphoria so that their physical body more aligns with their internal sense of gender, there are a lot of folks who don't identify with that binary representation of gender. So this is why we don't assume what someone's gender journey might look like just because they identify a certain way. So let's briefly talk about some of the gender journeys that we might see with patients. So social transition is about the coming out process, ultimately, communicating to friends and family about a new name or new pronouns. It could be new ways of dressing or how they present themselves. And for a lot of folks, finding a gender expression that fits someone in this way may be all that they end up wanting for themselves. Body modifications are another route that people take. So this could be reversible ways of altering our bodies, including things like tucking, padding, or binding. Another path is legal changes to a person's gender marker or their name on their legal documents. This is a fairly expensive process and not always accessible. So remember, it's really common that a lot of trans and non-binary people will have a name that they use that's different than what's on their legal documentation. And then lastly, we do have medical and surgical options for both trans youth and adults. And this can look like hormone therapy, puberty blockers for adolescents, or even top surgery and or bottom surgery. So ultimately, this process of figuring out our gender is very normal. And what people want for their bodies is really variable. So the best thing that we as healthcare providers and allies can do is just normalize this conversation around gender and provide support where we can. So this last concept is sexual orientation, and this is how a person identifies their physical, emotional, and romantic attachments to others. And in healthcare, we need to know not only how our patients self-identify in order to respect them, but also we need to know their behaviors in order to provide appropriate preventative health screenings. And this comes more into play for our family medicine providers. So labels for our identities mean different things to different people. And the most important thing to remember is that it's absolutely okay not to know what they all mean, but to recognize that there are a lot of ways that we self-define ourselves and to use the label that your patients have given you and not assuming a label that's based on appearance, partners, or behaviors. So again, just a reminder, when I show a big list, I just want to let you all know I'm going to give you all this afterwards, but just to kind of show you some outdated terms and some recommended alternatives. As terminology evolves, it's important to avoid some of these outdated terms that could have derogatory connotations to them. And we recognize that sometimes the terminology that the medical community uses doesn't always represent the lived experiences of the communities that we're serving. And a lot of this is a shift away from pathologization of LGBTQ plus identities and more of an advocacy approach of this concept around nothing about us without us, meaning that we're starting to listen to LGBT people around the language that they want us to use and how they want to access healthcare. So some other terms to know, but I'll just highlight the last three that come up pretty frequently for our patient population. So dead naming, this refers to using a trans or non-binary person's former or birth name instead of their chosen name. Misgendering refers to using a set of pronouns for someone based on the assumption of how they look or sound. And both of these are incredibly damaging to someone's trust in our healthcare system and providers, and can really contribute to poor mental and physical health outcomes. And then this last one is outing. So this is the involuntary or unwanted disclosure of another person's sexual orientation or gender identity. And this becomes important when we start collecting SOGI information, as well as referring to people in our waiting rooms. So I'm going to go a little bit into the experiences of gender diverse people in healthcare settings, just to give you a little bit of taste. These are some quotes from some patient experiences just here at the University of Utah through our press gaining surveys. And I think it just highlights a lot of the gaps that we're still seeing as a healthcare system around this. So many transgender people will delay or avoid seeking medical care because of fear of discrimination or stigma. And we won't dive into that in this presentation, but I just want to make you aware that that is a very prevalent issue and is very heavily researched. So we have a lot of literature to support that. So microaggressions are the most common experiences that our patients tend to report to us. These are insensitive comments that are painful because they have to do with a person's identity that's discriminated against or subject to stereotypes. And they typically happen casually, frequently, and often without any harm intended. So many marginalized groups experience microaggressions or also minority stress, and this is multiplied when you have those intersecting identities across race, nationality, age, disability, etc. So these communities are very acutely aware of subtle slights in body language that give an indication that you're not comfortable around them. So research shows us that microaggressions take a toll on both our mental and physical health, and it impacts all of our environments, and healthcare is not exempt. So these are tied to what's called implicit bias, which are these attitudes, stereotypes, and assumptions that we may not necessarily be aware of, but can affect how we act and how we treat other people. So the good news around this is that once we're kind of aware of these biases, and once we know what these microaggressions can look like for these communities, we can ensure that we're not perpetuating these in practice, and we can hold each other accountable. Okay, so now I'm going to rush through kind of the last part of the presentation, which is the application piece of best practices. So a great way to provide affirming care to patients is through the use of pronouns. Pronouns are used by everyone, but we typically assume someone's pronouns based on their physical appearance or how their voice might sound. So when we ask and use patients' pronouns, we're saying pronouns are a normal thing. Everyone uses them, and I respect you, and that's why I'm asking. So it's absolutely okay to apologize and move on when you make that mistake, but don't linger on that apology. Patients respond really well to us just correcting ourselves and then ensuring that we're using the right pronouns moving forward. Examples of how to ask our patients this could be, how should our staff and providers refer to you? Or may I ask what pronouns you use? And the goal here is to ask this of all of our patients, so we're not singling out folks who we might think are LGBTQ+, because this could put them in an unsafe spot by potentially outing them. Some communication tips to incorporate another best practice tip, which is gender neutral language. You can use they, them, or the patient's chosen name to ultimately avoid misgendering someone if you don't know their pronouns yet. Gender neutral, by using gender neutral alternatives, we avoid unnecessarily gendering terms and identifiers and allow our patients to fill in the blanks with what language they would like us to use. So you can see the list of terms that kind of come up frequently when collecting information of patients on the right-hand side and their gender-neutral alternatives. And then some tips on the left-hand side of kind of how to incorporate that. So collecting SOGI data is really important for this patient population as well, because if we're not asking, we just don't know. So you can find a bunch of tip sheets and a lot of information on SOGI data on the SOGI Training Pulse page. A note here that the university doesn't currently require this. However, in the next year, we are hoping to implement a training program to start this process for folks. So the more comfortable providers and staff are with asking SOGI questions, the more comfortable patients will be. And patients have the opportunity to enter this information ahead of time in their MyChart or a patient portal. Legal sex and or name can only be edited if you have that documentation from the patient that they've legally done that. And then on the right-hand side within our field options for EPIC are the recommended ways to ask these questions of patients. So what is your current gender identity? What sex were you assigned at birth or on your original birth certificate? And do you think of yourself as for sexual orientation? And this kind of gives folks an option to be more fluid in their answers and update over time. So if patients are hesitant to provide this, you can remind them as it's protected by HIPAA, it's kept in their medical record, and it's asked of all of our patients for quality purposes. So real quickly, to update a patient's chosen name, you can easily click on that squiggly N in the name box, and there's an option for what's called preferred name. And you can ask your patients, do you have a name that's different than what's on your insurance? What name would you like me to use, or could your chart be under another name? And then lastly, pronouns. So you can view pronouns by hovering over the patient's name. This is important to look for before interacting with a patient or documenting any notes. If pronouns are not populated and you have clinical access, you can click on the gender in the storyboard and it'll bring up the SOGI Smart Form, which then you have the option to input those pronouns. And then some final do's and don'ts. So do mirror the language a patient is using about their identity. Do refer to patients by their chosen name and pronouns. Do ask when you're in doubt. Do respect a patient's choice in how they identify. And do frame all of your questions in a respectful manner. Some don'ts are don't assume anatomy based on legal sex or gender marker. Don't use stereotypes or ask questions that are not necessary for care. Don't assume a patient's orientation or identity based on gender, appearance, partners, or behaviors. And then don't assume that all patients will use traditional labels. So now that you have all this, how do we anticipate our next interactions with patients? So we need to remember that LGBTQ+ people, including trans people, have a history of experiencing stigma and discrimination and trauma in healthcare settings. So don't be surprised if a mistake results in a patient becoming upset. You don't have to personalize that reaction. However, do apologize, because it will establish that reconstructive dialogue and recreate that safe space for the patient. And then don't be afraid to correct colleagues if they make insensitive comments or happen to just make a mistake too. Okay, so here are some resources and then information on how to get a hold of us. And again, that will be available to you afterwards. And I realize I went a little bit over time. So are there any quick questions or thoughts around this?
Yeah, I want to thank you, Ariel. Thanks so much for speaking to us about a complex topic in a quick little space of time. I appreciate it. And everybody, again, we'll have the pleasure of having Ariel back and having a longer session on this. But this is just a beginning to have us keep in mind to help our patients. Thank you so much.
Okay, thank you so much.